Okay, so good afternoon, everybody. Thank you for joining our today's webinar, which is entitled Clinical Practice Recommendations for Physical Therapy for Huntington's Disease. And it will be presented by Professor Bernhard Landwehrmeyer from the University Hospital Ulm in Germany. My name is Anja Hermans, and I work at the Institute for Medical Genetics at the University Hospital Tübingen in Germany. And in Tübingen, we are coordinating the European Reference Network for Rare Neurological Disease. So this webinar is part of a webinar series which we have started together with the European Reference Network for Rare Neuromuscular Diseases and with the European Academy of Neurology. Just a couple of words on those reference networks, because we have a worldwide audience here and not everybody is familiar with these networks. So these are virtual networks and are actually groupings of expert centers across Europe. And each of them, there are 24, and each of them has an expertise in a specific disease field or covers specific organic system. So we are covering the rare neurological diseases. And the goal of these networks, which were established in 2017, is to promote collaboration between the expert centers to facilitate sharing knowledge, sharing experiences, and with the final goal, of course, to help patients to improve the quality of care, to ensure timely diagnosis, etc. So we have in our network 32, at the moment, 32 full members in the dark blue countries and 10 members, affiliated partners in the light blue countries. But in 2021, there will be many more to integrate our network. So we will be expanding. And our network is covering 6 disease groups, which you can see here. So the topics of our webinars are always on in these disease groups. Okay, so short information also on, or in general information about the webinars. These webinars are on rare neurological, neuromuscular, and movement disorders, and on neurorehabilitation. So this today's webinar has a focus on neurorehabilitation. We have approximately 40 to 45 minutes presentation, and at the end we have 15 minutes of questions and answers. So please write your questions in the Q&A box and we will address them at the end of the webinar. We are recording this webinar, so it will be published at in 2 weeks' time approximately on our website here. And you can also check another part of our website. This is the Disease Knowledge Hub. So there are hubs on each of those 6 disease groups, and you can check the Chorea and Huntington Knowledge Hub. And after the webinar, your browser will open automatically a post-webinar survey. So please take time, 2 to 3 minutes, just to fill it out and to tell us about your impression and maybe to propose topics for future webinars. Okay, and we have also patient representatives or patient advocates for each of our disease groups. And Astrid Arnesen, the president of the European Huntington Association, is also a patient advocate in our network for the disease group, the Chorea and Huntington. So let us see a short video she has recorded as a message to the attendees of our webinar.
Hi, My name is Astrid Arnesen, and I am one of 6 patient representatives in the Rare Neurological Disease networks, and I'm very happy for your attendance at this webinar. One of the main objectives of the network is to share knowledge and bring clinicians together to discuss best practice. As patient representatives, we have very high aspirations for the network, as we want every rare disease patient to have access to expertise when needed. And webinars like this, and not the least a network of colleagues, we strongly encourage you to make use of this shared knowledge among colleagues when faced with the unknown. Because, let's face it, nobody, no matter how well trained or experienced you are, can know everything. And patients recognize that. We don't expect you to know everything firsthand. But faced with the unknown, we expect you to say, I will consult somebody else who may know more about this. Because as a collective, knowledge gets multiplied and even better further developed. This is, in our opinion, one of the main objectives of the European reference networks. I wish you a very good webinar and hope you will stay curious.
Okay, thank you, Astrid, for this nice video. So you have like this, the perspective from the patients and patient representatives. And now we come to our speaker today. I would like to present Bernhard Landwehrmeyer. His current position is full professor of neurology at the University of Ulm in Germany. He has obtained his training or medical degree from the Albert Ludwig University of Freiburg in Germany and has completed his residency in neurology and psychiatry. He has also done additional postgraduate trainings at the Kantonsspital in Basel in Switzerland and a research stay at the Massachusetts General Hospital and the Harvard Medical School in Boston in the US. So 3 of his key positions are, he was one of the founders of the European HD network and was chairman of its executive committee in the first 10 years since the constitution. He is since 2011 global PI of Enroll-HD. So it's a worldwide prospective observational Huntington disease cohort study for HD families, and it's sponsored by the CHDI Foundation in the US. And he's director of the HD Center in Ulm, which is a multidisciplinary center providing genetic counseling, clinical in- and outpatient services, as well as rehabilitation for HD affected families. The research of Bernhard Landwehrmeyer focuses on neurodegenerative disorders such as HD and Parkinson's disease, ranging from bench work to clinical studies. And he has published many papers in very prestigious journals such as Cell, Lancet Neurology. So we are very happy to have such an expert today with us. So thank you, Bernhard, for taking your time, for sharing your knowledge with us. And the floor is yours.
Great. Thanks a lot. And a real pleasure. And so it's truly a delight to be in the position to talk to you today. Can you see my screen all right?
Yeah.
Okay, perfect. So what I'm going to talk about today is physical therapy in rare disorders, at least initially, and discuss with you the reality that for many rare disorders, we rely on impressions rather than evidence. And I will discuss the impact of that for our clinical practice. In the context of HD then, I will discuss with you first the way of introduction, the clinical presentation and the natural history of HD, and discuss with you as the core of my presentation, physical therapy with the intention to ameliorate symptoms and signs. That is, physical therapy as symptomatic therapy, symptomatic non-pharmacological therapy. Then I will go on to discuss with you a physical therapy or physical activity as an intervention to go beyond this and potentially even modify the course of the disease. This is with a question mark, because I would like to discuss it with you. I believe that is an issue that is yet to be settled by future research. This comes in two flavors: short-term, often in the context of rehab, where you are trying to improve on the current state of a given patient affected by Huntington's disease by rehabilitation. But there's also a flavor in particular for those who know that they do carry the HD expansion mutation, and that comes in the flavor of lifestyle. And I will close with discussing, from my perspective, some of the challenges that lie ahead of us. I have put together a couple of learning objectives. And first of all, it's descriptive, variable clinical presentation of HD, explaining the root cause of the variability and describing the natural history of HD. Then I would like the folks listening in on the webinar to be in the position to state the important PT approaches and interventions, and to understand the current rate of evidence for various PT interventions, and finally to be in the position to describe novel approaches and efforts currently underway, and to identify practical challenges in implementing PT interventions in real life. So before we do start with the contents, I would love to know you a little bit better, so to learn who happens to be in the audience. And you do see, I believe, now a list of options. I believe more than one option can be chosen. Is that correct, Sanya?
No, this is only one. They can choose only one option.
Okay, so whatever is most appropriately describing your activity.
Okay, we will let 10 seconds more for everybody to respond. Okay, so I will show now the results.
All right. Oh, high proportion of physiotherapists. That's terrific. And I'm delighted also to see some researchers and patients and patient representatives joining us. That's terrific. Okay, thanks. Okay, well, I'm delighted then to proceed, if I can. So, let me start with the reality in rare disorders with respect to many interventions, physical therapy included. And these are, first of all, our clinical impressions from our practice. And I think this cover and this picture captures very well what the perception is that many of us, me included, have in their minds. Activity is a good medicine, in particular if you're talking prevention. We have an additional source of evidence, and that's a recent one from the SARS-CoV-2 pandemic. And I think for our center, it's true, and I believe that's true for many other centers around Europe as well, that many people affected by HD had, during the lockdown associated with the pandemic, had no access to PT or other co-therapies. And in a way, although totally unintended, it highlights and reinforces the clinical impression that PT and other co-therapies are important. The impression that we get is that many patients did deteriorate functionally to a clinically relevant degree because of the lack or the withdrawal of therapies that in many instances they get prescribed on a regular basis. So that's some sort of evidence, thanks to the SARS pandemic. If you talk to people affected with HD and their caregivers about their perception, and this is taken from a very nice review that I can highly recommend to you by Fritz et al. The perception is that there are clearly tangible physical benefits with respect to gait and balance associated with PT, but quite importantly, there is also social benefits. There are social benefits, and an increase in independence, self-confidence, and an opportunity to socialize and improve social relationships. I believe an important aspect overall of an intervention like a PT intervention. For many rare disorders, we have a concerning lack of evidence, however, hard evidence as to the efficacy, the limitations, and the benefits of interventions like physical therapy. So that has been improving, that situation has been improving over the years in HD. And that is thanks to the activities of a fair number of groups. And I would like to highlight Laurie Quinn and Monica Buss group in Cardiff that did help together with working parties. Here is one example of an opinion piece by the EHDN Working Party on Physiotherapy. And now advancing to even further higher grades of evidence supporting the use of physical therapy over the years. So we are looking at a trajectory that is indicative of a gradual but pretty impressive improvement of the evidence available to us, speaking to the benefits and the limitations of PT. Latest recommendation published, and it was published this year in Neurology. It's a clinical recommendation to guide physical therapy practice for Huntington's disease. And I think it's impressive to see that for a rare disorder, we do have grade A evidence, as well as a fair amount of grade B evidence, along with expert opinions. So if we look at it, we do have grade A evidence that aerobic training with or without resistance training does improve in fitness and motor function in HD, and that supervised gait training indeed does improve certain features of gait. And I think that's pretty impressive to see this for a rare disorder. We have grade B evidence also that you may improve by appropriate interventions balance. But it turns out that one of the objectives that all of us had in mind to modulate the frequency of falls could not be really influenced, at least not with the interventions studied today in a formal setting. Respiratory function can improve, and caregiver education is beneficial, and for folks in later stages of the disease, transfer training and getting up on various education and training programs appropriate for later stages of the disease have grade B evidence. I would like to highlight to you a couple of reviews. Here, the review that I was just referring to, published first author Laurie Quinn and Nora Fritz in Neurology. If need arises, please request a PDF from me if you don't have access to it. Both reviews, the earlier one from 2017 and the latest one from 2020 are worth reading. There are also other resources, for instance, the Working Party on Physiotherapy published clinical guidelines for Huntington's disease of the European HD network, that is. And I personally believe that a physical activity workbook published by the Cardiff group in the context of the Engage HD study is worth reviewing and using as a resource. For those of you who are comfortable with English, I personally find the resources as provided by the HDA of the UK very helpful, and you see in the bottom of the slide a web resource that you can resort to. Let's now discuss physical therapy in the context of HD in more detail. Let's start with reminding ourselves that the clinical presentation of HD is quite variable, despite the fact that HD is a monogenetic disorder caused by an expansion mutation, too much of a base triplet C, A, and G in the first axon of the Huntington disease gene and on the short arm of chromosome 4. And the CAG expansion size is important. You can see here that it is largely dependent on the CAG repeat size when the clinical manifestation of HD appear. The longer the CAG repeat, the earlier the onset of the disease. Here you see a patient, typical patient, with distal hyperkinesis in a earlier stage of Huntington's disease. You see a peculiar gait pattern as well, and you do see the distal the hyperkinesis, the choreatiform movements, most prominent distally. Here you see a patient in an advanced stage of Huntington's disease with ballistic movements, where now hyperkinesis affect the proximal joints as well, causing obvious problems both for the patient as well as for the caregivers. However, Huntington's disease may look like this as well. Here you see a young gentleman with obvious dystonia, asymmetrical. You see perseveration, applause sign in this young gentleman. And if we go to even younger people having manifest Huntington's disease, you see very prominent dystonic features and bradykinesia. This young chap requires PEG feeding as well, and you see very prominently the dystonic features. So first important insight in the context of HD is that the clinical presentation of HD depends on the size of the CAG expansion mutation. The more you have, the more dystonic and bradykinetic the phenotype, with lower expansion sizes, the choreatiform movement disorder predominates. It's worth looking briefly at the natural history of HD. HD is more than a movement disorder, and it's in reality a neuropsychiatric disorder. Personality changes, cognitive defects, along with the movement disorder, and the root cause of all this is a dysfunction of cortico-striatothalamic circuits due to a degeneration of basal ganglia in the first place. One of the areas within the brain most involved in motor learning. So that we have 4 symptomatic domains for Huntington's disease: the movement disorder, behavioral symptoms, cognitive syndromes, and metabolic disturbances. All are relevant for PT interventions in the context of Huntington's disease. HD, and I believe everybody who does treat HD patients and sees HD patient has one characteristic, and that is HD is devastatingly progressive. You see within the course of 13 years, a person reduced to a skeleton entirely dependent on assistance and help by others. Characteristically for HD, as we are all aware, is the long course of Huntington's. There's a long period where you have no symptoms and signs that are obvious or apparent. And so you have a long, if you like, pre-manifest or pre-symptomatic period followed by 4 to 5 stages of Huntington's disease that eventually end up in a state where you're dependent on assistance by others. And so you see very clearly that there is a soft sign that emerges first before you hit the threshold to make a formal diagnosis of Huntington's disease, currently anchored by the emergence of diagnostic motor symptoms and signs, although this is a moving target for numerous good reasons. If you look at large natural history studies, and if you do have large ones, Enroll HD, for instance, a worldwide study with currently more than 25,000 participants overall in various regions of the world, and you realize that disease signs emerge relatively late as a symptom and sign of a declining health of neurons, and where for a long period you have neuronal dysfunction that is eventually then made irreversible by an increasing proportion of neurons to die off, and thus impeding or the ability of modulating the clinical symptoms and signs in late stages of the disease. However, you have a very long period where neuronal dysfunction predominates, and that is where we, with our interventions, be it pharmacological, be it non-pharmacological, can interfere in a meaningful way. Let's focus on this long period, the clinically silent period, the so-called asymptomatic stage. I think it's important to realize that this year, the group of Sarah Tabrizi studied very impressive study focusing on young adults and people far away from predicted onset, and it studied in a systematic fashion, showing that no clinical alterations are measurable, but you can see that certain morphological features, atrophy of the brain, and very importantly, a biological marker, NFL, appears to be altered in a measurable fashion relatively early on. You can clearly see, however, that prior to 20 years, prior to predicted onset, there is a paucity of symptoms and signs. And if we add wet markers like the mutant huntingtin in CSF, that appears to be in correlation with the emergence of clinical symptoms and signs and the stage of Huntington's disease. And you can see very nicely that the neurofilament light, or NFL, in CSF, in cerebrospinal fluid, appears to be quite changed early on, and you can see this reflected in blood, in plasma as well. So if you integrate all this, for conceptually obvious reasons, you do see in the presence of mutant huntingtin in CSF. By the way, in the presence of mutant huntingtin in blood is of less significance in that context. You see plasma and CSF NLF changes followed by imaging changes captured by MR before you do see clinical alterations, often picked up by cognitive tests prior to the emergence of motor symptoms and signs. So, and the important insight from these studies is that in Huntington's disease, onset and progression are driven by the cumulative exposure to mutant huntingtin gene products, which is captured by the so-called CAP score as a measure of that exposure, and that allows us to come up with heat maps what to expect in a given patient depending on CAG repeat length and age. This is emerging but extremely helpful for many outcomes, in this case simple digit modalities or cognitive tests, but would apply for many other features of HD as well. Now let's focus on a brief review on the general benefits of PT. And the question of compensation. What is it that holds the HD affected person in good shape, despite the fact that for obvious reasons the HD expansion mutations is present from the moment of conception? What holds dysfunction at bay for so long? There are several factors. One, that organisms are intrinsically built that way, that they can compensate to some extent. A, by a functional reserve. You don't need all the cells in the body for the body to function just right. And by a so-called homeostasis, that is in the ability of the body to keep things in balance. It is this aspect, to keep in balance, where the intervention of physiotherapy in various flavors comes to rescue and helps, restoring balance, maintaining, supporting, fostering compensation. Before we review that, let's first focus on ameliorating symptoms and signs of Huntington's disease. That's the most common, as I alluded to in my brief summary of the available literature, the most common application of PT, ameliorating symptoms and signs of Huntington's disease, in particular gait, features, and overall physical fitness. But can it also modify the course of the disease? Well, preclinical studies in synthetic models of Huntington's suggest that that can be the case. There are numerous studies to support this idea. And we can look at this in particular in the context of rehabilitation. If you look of how we do rehab, in general, in practice in Huntington's disease, is that most centers, I believe, that's a fair statement, most centers do provide care in an outpatient setting, and that's obviously appropriate in early stages of Huntington's disease and what we may call prodromal stages of Huntington's disease. Home care and acute care in middle stages of HD and in late stages of HD also has a place, all coordinated in the ideal world by the appropriate HD center or HD clinic. most of the evidence that we have is targeting early to mid-stage HD patients. And thanks to our colleagues from Italy in particular, we have very well done observational studies suggesting a positive impact of multidisciplinary rehab programs on numerous readouts, including physical function, balance, swallowing, independence, mood, and social relationships. There are limited data provided from controlled study that, for instance, a 12-week community-based program, rehab program, was safe, feasible, acceptable, and beneficial. And as an example for numerous studies that have been conducted in the past, I would like to alert you to a Norwegian study that was published by Jan Fritsch and colleagues, an intense rehab program in patients starting in 2009 and based on the landmark observational studies that I just alluded to from our Italian colleagues. So this was an ambitious program, a 1-year program with 3-week stays in an inpatient rehab repeated 3 times over the course of an entire year. And here are the locations where this happened. So what was used as a readout at baseline and was also assessed and evaluated at the end of each stay with a particular focus on motor function, balance, and gait. The program was intense. 8 weeks, 8 hours of activities for 5 days a week and in small groups, pretty comprehensive. Using a multidisciplinary team, not only including physiotherapists, but also physicians, nurses, occupational therapists, speech therapists, dietitians, social worker, and psychologists. The main finding of this Norwegian study, published in PLOS for Huntington's disease, was significant improvements in gait, balance, physical quality of life, anxiety and depression, as well as BMI, with stable ADL functions with no significant decline over the course of the study period, that is a year, and a trend or a question mark concerning its impact on cognitive measures, in this case, simple digit. Now, even more interesting, is PT as intervention in the position to modify the course of HD in the sense of delaying onset or slowing progression? This is beginning to be studied, and one of the studies that I would like to draw your attention to is the PACE HD study. That is focused on exercise outcomes in Huntington's disease patients, a phase 2 study, 1-to-1 randomized control intervention study, where 2 interventions are compared, activity as usual and physical therapy and exercise intervention, including wearables. The aim is to establish, first of all, feasibility, and to explore estimates and obtain estimates of effect sizes, and in particular for physical activity and endurance, and various readouts for motor function over long term. Very important. This is a multi-center trial conducted in Europe and the US, in a number of HD centers. Included and enrolled into the study were individuals with early to mid-stage HD. And the data to characterize the HD phenotype was in part related through the involvement of the participants in the Enroll HD study as well. You see here the study plan. 116 individuals were recruited and the recruitment rate of 28. 57 individuals were enrolled in the randomized controlled trials and the other half in the observational cohort, with a very high retention rate and a good completion of the final assessment. Outcome measures used in the PACE-HD study for the construct fitness was an VO2 max measured by ergometry, so pretty an objective parameter, walking endurance assessed by the 6-minute walk test, and physical activity using both questionnaires as well as variables, in this case gene active accelerometers. There were more readouts, and the intervention consisted of 1-to-1 physical therapy session focusing on increasing physical activity at home, fit devices to track activity and to monitor goals, the ability to, in an individualized fashion, identify equipment, or if the participants choose to do so, use community-provided engagement opportunities with an HD-specific exercise workbook to educate about physical activity and goal setting in this domain. The study, PACE-HD, despite Corona, has been completed, and we are eagerly awaiting the results. So stay tuned, and that hopefully gives me the opportunity to present at another day again on this exciting topic. It's quite clear that long-term studies are needed to explore the impact of PT or defined interventions on the rate of progression. These studies, to my mind, need to be supplemented by biomarkers. I showed to you some of the natural history results, highlighting the fact that NFL, both measured in blood as well as in CSF, appears to mirror to some extent the natural history of HD. There are other markers as well that can be discussed. I believe that's very important going forward to incorporate such biomarkers in efficacy explorations of physical activity. What are the challenges ahead? We need to define who to treat when. I think it's pretty self-evident from what I described to you so far that different goals apply, different interventions are required for folks in prodromal stages of HD as opposed to those in the mid stages, as opposed to those in the advanced stages of HD. We do need to define the intervention and the precise goal of the interventions. For instance, I'm pretty impressed that in some people with pretty ballistic chorea, chorea seems to respond to a change in sensory stimuli, akin to the well-known phenomenon that by change in sensory stimuli, a jest antagonistic dystonia can be modified. And that's pretty important and interesting to pursue, as well as a lot of other interventions. Defining those, to me, is a very important issue where we don't have a clear answer. This is taken from high-performance athlete textbooks, showing that you need, following training, a recovery phase that hopefully would result in supercompensation and real growth of your ability that will eventually elevate your performance indices. But it's well known that you can also overdo it, and that if you do not pay proper attention to the length of the recovery phase in relation to the training that you applied or that you took part in, you can be faced with the problem of overtraining. That's also well known for people, let's say, with ALS, where it is not wise to fatigue people, and that will not help on the long run in stabilizing functional performance of folks affected with the disease. Defining outcome measures is equally very important. We cannot rely solely on the traditional measurements for the phenotype of HD. We need to expand here, and like I illustrated for you for the PAGE-SD study, rely in an intensifying fashion on variables and other readouts that allow us to measure on a more ongoing basis impact that PT interventions do have. In practice, there are a lot of challenges in implementing physical therapy in a Huntington's disease patient. There, and this is again taken from the very nice review of Fritz et al. And there are factors that help in conducting a successful PT intervention. External environmental factors, for one, commitment to the therapist, for instance, to the caregiver, the engagement of the caregiver, but also personal factors like the need to be efficacious and to set goals and to be ambitious reaching the goals, and identifying those factors that work for a given individual. For instance, being part of a group with common goals and various ways to make it part of your routine in order to adhere to a continuous training. There are barriers, however, and those are very, very clear. From some point onwards, there is an impairment of motor learning as a result of the increasing dysfunction of the very brain structure that is central to motor learning, that is basal ganglia. And cognitive impairments, understanding the instructions, understanding what is asked from you, do contribute. And very, very important, the lack of motivation. I would refer to it rather as apathy. It's a common observation in HD in particular that folks affected by HD perform in daily life, in regular life, below the level of what their brain and their bodies would allow in principle to do. But that's an important feature, apathy, of the disease for which we do not have an appropriate pharmacological treatment. PT, I suggest, could be one way to combat apathy. Participant fatigue is another issue, in particular as you advance in the physical impairments and with increasing severity of the disease. Participant fatigue is an important factor. Caregiver fatigue is equally an important factor. At some point, you get tired of arguing and trying to stimulate with the HD affected person. And as a result, the PT activities are poorly maintained or given up altogether. Here, telehealth may offer some additional avenues of bringing motivation and overcoming an apathy. And circling fully back to where I started, this may be in part thanks to the coronavirus. The pandemic situation is shit, I quote this here, but it may be our fertilizer for the future. The president of Estonia had this as a motto, and I think it helps us in our current struggle with the pandemic as well. It is obvious that you're limited in fully picturing what the situation is like for folks, and the health video supported calls and the like may help you to get a more appropriate idea as what the reality is like, and that helps you seeing the reality to make more appropriate and more realistic recommendations overall. And that is formally explored in a program supported by JPND, where a platform is supposed to be built, and that is hopefully going to support bringing these telehealth options to our patients going forward and to their families to support not only the HD affected, but also their families. So here are my key points and conclusions of the presentation that I had an opportunity to give to you. There is evidence that PT has a beneficial impact for people affected with HD, at least with respect to symptom relief and short-term improvement. And that's true for most stages of Huntington's disease. So rehab, in my opinion, does make sense, and we do have proper evidence to support this. However, there is currently a lack of evidence for long-term impact and the potential of PT to modify the natural course of HD, in particular in early or premotor manifest prodromal stages of Huntington's disease. And in order to make progress in these important areas, we are dependent on developing novel assessment tools, e.g. biomarkers, to make such studies conclusive as well as feasible. And lastly, telemedicine may offer new avenues to deliver PT and to assess real-life impact and benefit. I would like to acknowledge my colleagues, in particular Laurie Quinn, Monica Booth, the PACE study sites and their PIs, as well as Una Jones and Dr. Rao, for being fantastic colleagues and helping me with preparing this particular presentation. And of course, I'm deeply indebted to all those folks affected by HD and their partners and caregivers with whom I had the opportunity to interact and from whom I had the opportunity to learn. Thank you very much for your attention, and I am looking forward to discuss with you questions.
Yes, thank you, Bernhard. Great presentation, very clear and instructive. And there are already some questions, so you can interact with the attendees. Mm-hmm. So how sensitive is the repeat expansion detection in HD gene, as I have a patient with positive family history of HD and start to have mild Chorea and Gait abnormality, although his repeat expansion number within normal range?
All right. So if done with the appropriate techniques, and typically this is a PCR test using two independent primer pairs, and the assessment of the CAG expansion size is pretty accurate in general. What you need in the laboratory, however, is proper size markers, in particular along the critical borders. That is 36, which defines whether you have or have not likely HD, and 40 CAG repeats, which defines whether it's fully penetrant or not. So this is one issue. The second issue is that if you have bad luck and happen to have genetic modifiers, you may have a subthreshold CAG repeat size in peripheral blood, let's say 35, and because of a phenomenon referred to as somatic expansions, larger repeat sizes in other cells of the body, in particular in your neurons within the brain and the striatum in particular, that may give rise to signs and symptoms. That's rare though, and I personally find it difficult or do not know of many examples below 34, 35 and CAG repeats. Another possibility that we observed, in particular our colleagues in the Netherlands observed, and quite frequently in their carefully conducted case studies, is that folks from HD family may display motor features that are acquired because HD family members copy the motor behavior of other family members, suggesting to the raters and to the neurologists this may, stresses on may represent an early stage of Huntington's disease. That's a possibility too. So, and in Raymond Roux's experience in Leiden, experienced raters were wrong in at least 20% of cases, guessing the presence or absence of a mutation based on the motor phenotype alone. So that needs to be kept in mind.
Okay, thank you. So then another question, we see visual cues improve gait. In this line, what are the specific measures to improve gait function, such as negative step length?
Okay, so I believe that's my impression as well, and an important component of the impairment of voluntary movements in HD in particular, that similar to Parkinson's disease, initiation of gait and cadence are most obviously impaired if you're reliant on the default subconscious automatisms hardwired in your brain. And so if you're using visual cues, and in that sense, it's similar to the experience in Parkinson's disease, where walking with the assistance of visual cues, let's say on a crossing across the road or using stairs, the system, the function of the system of your voluntary movements and of initiation is boosted by you using visual cues and not being entirely reliant on your automatism. What I tell my patients often is that HD is a little bit like driving a car. Having HD is like driving a car without a servo. So you can do it, but it's hard. So that's how I see in that sense many similarities between PD and HD, in the sense that the enforcement of intended movements is impaired in both conditions and can be ameliorated in both conditions by bypassing the automatic pathways that we normally rely on, and is assisted by having visual or acoustic cues.
Okay, thank you. Great thanks from Eddie Goris for your presentation, Bernhard. And another question now from Jose Esteban. Is there any recommended guide on which physical exercises are the most useful for improving the different motor deficits of Huntington's disease patients?
Okay, so to my personal read of the literature is that the best evidence exists for certain aspects of voluntary movements. That's in particular gait and various characteristics of gait. And for dexterity, finger movements and the like, the evidence to my mind is less compelling and less convincing. And there's very limited evidence in forms of rigorous study addressing the involuntary components of the movement disorder, that is chorea and dystonia. And here I do see a need for additional studies, and I briefly in my presentation alluded to the observation that it strikes me that changes in sensory input appears to have a calming effect on the extent and the amplitude of involuntary movements. So this, I'm aware that that is not a complete and comprehensive response to your question, but a lot of the evidence provided is in the neurology paper, and the first author being Laurie Quinn, that I alluded to.
Mm-hmm. Thank you. Do you have information how much Bobath treatment helps?
Okay, it's a good question, because many PTs working in the context of a movement disorder clinic or in neurology in general are well trained in Bobath treatment. There is, to my knowledge, no formal study that would allow us to quantify in any way the impact of these principles. I personally favor the idea that it is for a PT very important to consider the nature of the dysfunction of basal ganglia and the motor system in HD, and on that understanding base their interventions. Bobath, as everybody is aware, was focused on lesions of the so-called pyramidal motor system, and less focused on the so-called extrapyramidal motor system. So I believe that for that reason, it's one needs to critically adapt principles that are highlighted there and use the techniques that the respective therapist is very familiar with to explore the appropriateness of an intervention, but based on an understanding of what goes wrong in the brain, in the motor system, in these patients in all likelihood. And that is different from the garden variety, let's say, stroke patient, for which Bobath well, originally it was the other lesions of the so-called pyramidal system was designed for.
Okay, thank you. How to reduce falls in patients with HD having problems with balance?
Right. So a very important question, and here is my personal take on it. I believe that there is a period or a stage in HD where you can adjust and improve balance in a meaningful fashion. However, it is my impression that there is also a stage beyond which you are unlikely to be successful. And here's the reason why. If we recall how toddlers learn to walk and how toddlers react when they, for instance, see a ball in front of themselves and want to reach it, they will typically lose balance. Why? Because their brain their basal ganglia have yet to learn how to preemptively, before shifting the physical center of gravity forward by stretching out their hands, let's say towards the ball, how preemptively to adjust the muscle tone in your back, in your rectus spinae, in such a way that you keep balance. My impression is that this particular function of the brain, pre-adjusting to the intended movement, the tone of your trunk muscles appropriately, is lost in the course of HD because you lose the very substrate for doing this adjustment, that is the basal ganglia. If you agree with that view, the only way to deal with this problem is to use devices for a certain period, walkers, let's say, or personal assistance. But beyond a certain point, a degree of damage, I believe you can no longer prevent falls. What you can only do is limit the impact of falls by, let's say, protecting your hip, protecting your head, and alike. But you will not be in the position, that's at least my impression, be in the position to effectively restore balance.
Mm-hmm. Thank you. And another question connected to balance. Is there any evidence for the role of weighted vests for balance issues in HD?
Could you repeat this? Weighted what?
Vests.
Wrists. Okay.
Vests. Like Westen.
Okay. Yeah. I understand that. Okay. Well, okay. That's another really interesting question. I favor the view, let's put it this way, that depending on CD repeat length and depending on the duration of the disease, you do have other motor systems affected to the degree that it has clinical consequences in HD as well. For instance, your cerebellum. To the extent that, like for other cerebellar disorders, changing weight and assisting with respect to vests is emphasizing or de-emphasizing the impact, the physical impact of you moving your extremities in favor of the position of your trunk towards your trunk. And likewise for the extremities, by making them heavier by appropriate weights, you may to some extent modify the atactic component of the disorder. But as I believe everybody is aware, you have to find the right balance between making life harder for the affected person and improving certain features of their volitional movements by these types of interventions. So it's a balance question, and overall, I don't think it's, at least that's my personal experience, that these measures work in an impressive way in day-to-day practice.
Okay, thank you. I'm conscious about the time and propose to take one last question from Ferdinando Squitieri. He was our webinar speaker also some time ago. So what kind of physiotherapy would you expect may represent a real resource for HD? Aerobics versus coordination exercises, and why?
Okay, so thank you very much, Nando, for the question. So, in my thinking, it depends on the phase within the disease, the stage of the disease, what is most appropriate. I believe, for the reasons that I briefly alluded to in my presentations, that in early stages, I'm talking prodromal stages of the disease and even earlier, where aerobic exercise may have an impact on functional reserve. And functional reserves, not only within your brain, but also with respect to your muscles and your strengths and your dexterity, helps to prevent the emergence or delay the emergence of symptoms and signs because you have a larger reserve capacity. It's a little bit like folks with a very high cognitive reserve displaying minimal cognitive impairment later in comparison to those who lack this type of reserves. In terms of I personally feel that training dexterity and balance and volitional movements in particular is helpful if you start to be impeded in real life with respect to these functions, and then a varied and to the point training of abilities and of dexterity and coordination may help. I'm uncertain that in the very, very early stages where you're trying to boost the resilience of your overall body and your brain in particular, exercises or training of coordination skills and alike are of as much benefit as aerobic exercises appears to be.
Mm-hmm. Thank you. So thank you very much indeed for this comprehensive and a full answering of the questions. And there are even more, but we can't take them, all of them. But this shows the very big interest of our participants in all these topics, or in this particular topic. So thank you again for attending the webinar. Many people have already said thank you for this brilliant presentation. And we will have another webinar in 2 weeks. So stay tuned, stay safe, and please visit us again. Thank you again, Bernhard.
Thank you.
Bye-bye to everybody.